Welcome to PharmacyToDose, the Critical Care Podcast, a partner of the ACP Critical Care PRN and a member of the Pharmacy Podcast Network. And I'm your host, Nick Peters. And wherever you are and however you are listening, thank you. And this is the October Trial of the Week, and we are reviewing a landmark study today in emergency medicine featuring tranexamic acid. I'm joined by Ruben Santiago to discuss the 2019 Lancet article, CRASH-3. We set the scene, review what previous studies found with TXA in trauma. How would Ruben characterize the ultimate findings, positive, negative? Then we dive in and dissect this study before discussing how we use TXA now, both guideline recommendations as well as in the viscoelastic testing era. And then also love that we get to highlight Ruben's 2023 PharmacyToDose Award, our social media star. So sit back. This is an absolutely fun trial of the week, and it starts right now. Well, this guest has been, I want to say probably over a year in the making, getting him on the pod, and it took winning an award to make it happen. Today's Trial of the Week guest, Ruben Santiago. Now, Ruben is an emergency medicine pharmacy specialist and RPD of the emergency medicine PGY2 program at Jackson Memorial Hospital in Miami, Florida. You likely know him from his Instagram account at the ED Trauma Assist, which award winner for the Instagram social media star for the 2023 PharmacyToDose Awards. Ruben, welcome. How are things down south?
Hey, what's up, Nick? Thanks for having me on the pod today. Things are going good, man. Still sunny outside. Everything's going great.
Yeah, and I think you're kind of in the same boat with the Texans that I've had on, right? Is basically like you survived melting season. I think that's what we're going to nickname summer down south. So you made it.
Yeah, exactly.
So first things first, gotta give you your flowers for the award, the awesome Instagram account. I guess the one question I have is what started it? What, like, was there something that like started the Instagram account to where it became now, or was it just kind of like a gradual thing?
It was more like a gradual thing. Like I was seeing other accounts out there, like looking at their take on healthcare. And I was like, I know I could probably do something. Not only would be educational, but kind of give my spin on certain topics and like present them in a way that hasn't been presented before. So it kind of started with like little ideas like that, and it's kind of just more and more people ended up liking it and finding it funny. I kept getting DMs and stuff, and I was like, all right, let's roll with it. Let's keep going. So I kind of kept it on.
It's really good. The one that made me chuckle most recently, it was it's a picture of Tyler Hero after he made a 3, and I think the quote was, "When the Vank level comes back right within range." He's kind of got this like snarl look on his face, kind of like doing almost like the Conor McGregor walk a little bit, like some swag. So it's very funny. Everyone give a follow. It is a great humorous take, especially from a pharmacist perspective on all that's going into healthcare. So let's get into the trial of the week, the CRASH-3 trial. And normally, okay, we're going to start a little differently. Let's start with a multiple choice question here. And when we're thinking about, there were other studies before, but thinking about the big ones before CRASH-3, CRASH-2 and the MATTERS trial specifically, how would you describe the prior studies with TXA in trauma? Would you say they're positive, neutral, negative, or is it complicated?
Overall, I would say that it was a net positive result from my take. Looking at the results from the CRASH-2 and the MATTERS trial. But when you actually dial into the data of like the other trials that have evaluated TXA in trauma patients, you almost go to like, well, maybe it's a little bit more complicated. So like overall, the two big trials did show a benefit in this patient population for trauma patients and those getting TXA. Like CRASH-2 kind of kicked off the party, the TXA party. And after those results were published, the TXA use like pretty much exploded everywhere. So every single trauma patient was getting it, even though there were some caveats and shortcomings with the CRASH-2 trial. So like not many patients got blood. like only 50% of patients got blood. When they did get blood, it was a low amount of blood volume that they'd receive. There were a lot of blunt trauma patients. It was done in, middle to low income countries without advanced trauma systems. With all that being said, though, those results were applied and kind of extrapolated to everybody using TXA. And then in the MATTERS trial, what really stood out to me was the benefit seen in that patient population were those patients who were receiving blood at the same time that got TXA, with more benefit in those receiving massive transfusion. So I think those two trials have a net positive result for the use of TXA in trauma patients, but there are some studies out there that also show that the use of TXA in some trauma patients had no effect.
Yeah, when I was training, the CRASH-2, I think, was like my first look at like how polarizing, when you look on the surface, right, and you look at the results, it makes sense that we were giving TXA to everybody. But that was your first kind of, the devil's in the details, and you go in and you're like, oh, I actually have like 15 notes about this trial and some of the findings and things. So you highlighted a few of those. What findings from those prior studies, what were signals or things or hypothesis generating outcomes they found that led to the design and creation of the trial we're talking about today, the CRASH-3?
So for the CRASH-3 trial, there were some smaller studies that looked at TXA and TBI specifically, and there was like a subset of the CRASH-2 trial that looked at TXA and TBI. And what they showed was when they put those studies together and did a meta-analysis, there was a statistically significant reduction in death with TXA use. But they didn't really evaluate or provide evidence on the effect of TXA on disability or adverse events. So that kind of, I feel, led to the jumping off point for the CRASH-3 trial. Like, hey, all right, we have this data now. Let's look at just patients with TBI. We know that patients with TBI can have a higher propensity of bleeding. Hematoma expansion leads to worse outcomes. And maybe this antifibrinolytic agent can help halt the bleeding and provide better outcomes. So that kind of led to the development of CRASH-3 trial. And CRASH-3 trial then followed also the same dosing regimen as the previous CRASH-2 trial and the smaller studies of 1 gram TXA bolus followed by 1 gram over 8 hours.
Yeah, let's hit some highlights on that. The CRASH-3 trial. Let's kind of get into the trial of the week. So published ahead of print in October 2019 in Lancet, titled "The Effects of Tranexamic Acid on Death, Disability, Vascular Occlusive Events, and Other Morbidities in Patients with Acute Traumatic Brain Injury," aka the CRASH-3 trial. So international, multi-center, randomized placebo-controlled trial. And this was 175 hospitals, 29 countries. So big variety. We'll talk a little bit about those countries probably in a little bit, but enrolled TBI patients presenting within 3 hours of injury. Their GCS was less than or equal to 12. Intracranial bleeding was seen on their CT scan, and no major extracranial bleeding, right? So they're not having other huge sources of blood loss contributing. So initially, in their initial protocol, the time window was from 8 hours of injury. But after the CRASH-2, the authors did an exploratory analysis, and that paper showed that TXA is unlikely to be effective if you give it after 3 hours of injury. So these authors changed the inclusion criteria to presenting within 3 hours of injury, and that led to changing their power calculation, kind of increasing their the sample size of who they needed to meet that power. Like Ruben said, we followed the classic trauma TXA dosing, the gram bolus, followed by a gram over 8 hours, with the primary outcome being 28-day in-hospital head injury-related mortality. Now, the authors plan to stratify the primary outcome by 3 baseline characteristics. So severity of head injury, and they use that based on GCS scores, time to treatment, and age. So notable that they did a pre-specified that they're going to do a sensitivity analysis excluding patients with a GCS of 3 and bilateral unreactive pupils. So for those who are maybe not involved in the care of trauma patients, that's a poor prognostic factor and probably poor outcome. So the thought would be, if we analyze without that, we'll maybe be able to get a truer sense of those that we could truly make a difference in. So just over 9,200 patients who were enrolled within 3 hours of injury, and 9,127 patients ultimately had that primary outcome data. So Ruben, fill in any gaps, anything you want to highlight methodology-wise, and then discuss what the authors ultimately found.
Yeah, for sure. No, you described it beautifully. So yeah, they included patients, like you said, within 3 hours of injury with a GCS of 12 or lower, or any intracranial bleeding on CT scan. And like you said, due to having those patients within 3 hours, they kind of brought down the amount of patients that they were able to analyze from around 12,000 to about 9,000 patients. But everything, yeah. And then we followed the TXA 1 gram bolus, followed by 1 gram over 8 hours for this trial as well. So I think their methodology was, hats to the authors, was amazing. They included a huge amount of patients, which we often don't see in emergency medicine, sometimes critical care literature, more EM literature, that we don't see that big of an N. So they definitely tried to make the best light of how we should use TXA in this patient population.
Yeah, and if you haven't been, when patients like this present in the ED, in the trauma bay, it can be chaos. So the idea of enrolling patients in a randomized trial with like a pharmacologic intervention, shout out to all the research teams, because it's certainly, that's not a calm environment. Lots of people, lots of things happening simultaneously. So yeah, kudos we gotta give a shout out to the research team. That's a really good point there. Now, what were the results of, what are some of the takeaways? Like, what did we ultimately find from this study?
All right, so like we were saying, there are about 12,000 patients that received either TXA or placebo. And of those, about 70% or about 9,200 patients actually got TXA within 3 hours of injury. So when they looked at that risk of head injury-related death within that 28-day time frame, it was 18.5% in the TXA group versus 19.8% in the placebo group. So not like a big earth-shattering change that we were kind of all hoping for. So once they did look at the data and kind of excluded, like we said earlier, those patients with a GCS of 3 or bilateral unreactive pupils at baseline, the results were slightly different. There were 12.5% injury-related death in the TXA group versus 14% in the placebo group. Again, not a huge difference that we were hoping for, especially when you want to do like your best for this patient population. So then what they did, they stratified it based off head injury. So they saw that there was a reduction in head injury-related death in patients with mild to moderate head injury, so GCS of about 9 and up. But this was not observed in patients with severe head injury or patients that presented with any non-reactive pupil. So if even one of the pupils was non-reactive, indicating some type of head injury, those patients did not improve in their mortality in the TXA group.
I want to point out real quick, because when the confidence interval, when they excluded those with a GCS of 3 or the bilateral unreactive pupils, confidence interval is 0.8 to 1. So what do you think? They ran that analysis like 200 times to try to get 0.99, right? Like that.
Exactly. Yeah. They're like, are you sure? Is it really 1?
Fragility index of 1, but it doesn't matter, right? We made it. Sorry. So go ahead. What else do they ultimately find? I always think it's funny when you see those confidence intervals and just seeing, right, like 5 patients change, and who knows what these results show.
Exactly. And then what they found was earlier treatment was more effective than later treatment in patients with mild to moderate head injury. When they looked at the time to treatment for a TXA in the severe head injury group, there was no obvious effect of time to treatment for that group. As far as any adverse events goes for this trial, the risk of vascular occlusive events, seizures and adverse events was also similar between groups. So that's a good sign. That's good. Yeah, that's a huge take home when you think about the risk benefit in these patients that present. Like, is TXA absolutely indicated? Probably not. Is it going to hurt? Also, probably not.
So let's talk about that primary outcome here for a second, because we talked about the time frame in this study is 28 days. And for those listening who are more critical care trained, work in the ICUs, right? Almost all the studies have gone to the 90-day mortality or looking at those kinds of things. What is it like? What is the most appropriate time frame, do you think, for a primary outcome like this? Do we know? Because 28 days almost seems like splitting the difference between like our EM and our ICU studies.
Yeah, I think 28 days for this study was appropriate. It allowed for the development of like any kind of adverse reaction that may have occurred from the administration of TXA. So looking at those outcomes, development of any kind of vascular occlusive effects that may have occurred. And what I did like about this study is they had a secondary endpoint of 24-hour mortality, which is kind of like more in our realm of what we want to look at, and that look the effect of TXA in that time frame. And those patients that got TXA had a relative risk or a risk ratio of 0.72 in 24 hours when you excluded the baseline of GCS of 3 and those with bilateral unreactive pupils. So that give us like a glimmer of hope for those patients. But then there's so many things that can happen within those 28 days as well that can affect mortality, whether these patients develop sepsis, did they get, VTE prophylaxis in a correct amount of time and all that kind of stuff, and all those other things where they are appropriate to line up to really affect see the true effect of TXA in that patient population.
And it was in hospital, right? So, you're thinking if they got discharged within a week or two, it's probably okay, right? But it's not. That's so easy to say, right? From a research perspective, following up when people get out of the hospital, especially in some of these countries where getting in touch with people could be harder, right? Logistically, it probably makes sense to keep it in hospital, but just things to kind of consider as we think about comparing this trial to some of like the methodology of how trials are getting created today. I think the other like big notable thing with the methodology and things is the change in enrollment criteria, right? And of course they had to do it, right? If we knew the 3-hour info and this was an 8-hour study, it would really be hard to know what to do with it. But how does the change in that enrollment criteria, how does it affect the interpretation of these results, the power calculations, things like that?
That's a great point. That I'm looking at it from like just from a global aspect, you would think that changing that criteria would lead to a net positive outcome.
Yep.
Right? Because these patients, you figure the longer that we're out from the initial traumatic insult, the less likely any kind of pharmacological intervention is going to do anything for this patient population. The injury's already there. You're not going to reverse anything. You're not going to prevent any further hematomic expansion or anything like that in those patients. So they did have to kind of like rewrite their stats, like you said previously, and then they also had less amount of patients to be able to analyze, from going from 12,000 to 9,000 patients. I mean, that's still a huge chunk of patients that they didn't include in their data set that could have affected their data set as well.
So thinking about where are we now with this study, because man, I mean, tranexamic acids had some of the highest quality studies when we think about like pharmacologic interventions. So knowing all of those, and we even had the recent patch trial come out, is there an ideal trauma patient population or subset of patients or something like that TXA should be considered as more of a first line treatment? Like, have we really like narrowed that down? Because I feel like the more you look into this, sometimes the more muddy it feels.
No, absolutely. And I definitely don't think it's a one size fits all. For TXA, there's definitely a subset of population that would benefit the most, I feel. I would say that patients that are severely injured, that are getting multiple blood products, and you think they're progressing on their way to a massive transfusion or a massive transfusion protocol is activated, those patients will probably be served best receiving tranexamic acid from a trauma perspective. If we're thinking just for a TBI perspective and just focusing on the CRASH-3 results, again, not a one-size-fits-all. I feel like if there's any benefit, it would be somebody with mild to moderate brain injury who has both pupils that are reactive at baseline.
Which is why this research is important, because I think if we went into the CRASH-3 trial, I would have assumed, right, that you would see it in the more severe, not the mild to moderate patients, but probably those moderate to severe patients. So if we're going to use it, like if they're asking you like, hey, we're going to make a protocol, maybe it's, out of hospital transport, et cetera. What is the ideal time frame? Is it the golden hour? Is it like stroke where it's 3 hours? Is it, do we know what time frame we should really try to give TXA in these trauma patients?
Yeah, it seems like time to drug is like for every single intervention these days, yep. Right? So yeah, I would think that as soon as possible and within 3 hours for sure. And it also depends on where you practice. If you're practicing in an area with like really short transport times where they're able to kind of like scoop up the patient and run to the trauma center real quick, and you guys can really assess if that patient needs TXA versus giving it in a pre-hospital setting, then it's probably a good bet. And if you're in a place with prolonged transport times, where they need to airlift the patient to get to a hospital, and then that hospital needs to transfer the patient to a trauma center or a high level of care trauma center, and you feel like TXA is indicated, then I think, like we discussed earlier, there are really low risk of adverse events that those patients could probably receive it as well. But definitely within, as soon as possible, and within 3 hours.
Where do the guidelines stand on this? Like, what are guideline recommendations?
Yeah, so there are a couple of guidelines that mention TXA for trauma patients specifically. So the European trauma guidelines just came out, and their recommendation is to give TXA in patients who are bleeding or have a significant risk for bleeding as soon as possible and within at least 3 hours of injury. And their dosing recommendation has remained unchanged from the CRASH-2 trial, so like 1 gram bolus followed by 1 gram over 8 hours. There's also the Joint Trauma System guidelines, and they kind of recommend administering TXA. Their dosing scheme is a little different. They recommend a 2 gram bolus as close as possible to the occurrence of injury and not outside of the 3 hour window. In terms of TBI, there was the NICE guidelines that was just published this past year, and when they're looking at their section on head injury, they actually recommend TXA as well. And their recommendation for TXA is a 2 gram bolus for patients with head injury and a GCS of 12 or less who are not thought to have any active extracranial bleeding. So I found that a little surprising based off the CRASH-3 results, that a whole guideline would be like, yeah, we should be giving this now. I'm like, oh, okay, because I felt like it was more hypothesis generating, like, hey, maybe we need another study just on this mild to moderate group and really figure out if TXA has a benefit.
A perfect example of how you have two large organizations that interpret and apply these results from the same studies differently. Because the vibe, especially when you've looked at the different iterations over the past like decade or so, is that the Europeans feel much more strongly about the TXA data, it felt like, than we did in North America or the US.
Absolutely. Yeah, no, I completely agree.
And then I think the other thing that we'd be remiss to not mention is, right, how does viscoelastic testing change our interpretation of these results, right? You mentioned one of the big kind of criticisms or limitations of the earlier studies, right, is that we're not at the level 1 trauma centers in the, US and things where, the treatment is going to be more of what we're used to, more of our standard of care. So how does the results from going to some, smaller centers, less established trauma centers, don't have TEG or viscoelastic testing? But when is TXA indicated according to viscoelastic testing, and what should centers do who actually have this available to them?
Yeah, like you were saying, it would have been amazing to see if they were kind of some TEG results as part of the CRASH-3 trial. Obviously, that didn't happen. And then patients that do get viscoelastic testing, it would have helped us correlate more to see if TXA worked. And what we do look at, trying to quote Dr. Brian Gilbert over here, shout out to him for all his work on TEG. What he always says, when in doubt, TEG it out, right?
Yep.
When looking at that, you look at the mark you want to look at is the LY30. So if the LY30 is elevated, that can indicate some type of hyperfibrinolysis that's occurring, and that's when your TXA would really benefit those patients. If your hospital does have TEG, that I feel like the decision to give TXA sometimes is independent of what the TEG results say. So like you have a patient that's in front of you that's requiring multiple transfusions. I'm not going to go back and look at a TEG. I'm going to give the TXA, right, in those patients. But if you do get a TEG and that decision was made not to give TXA at the time, and you have an elevated LY30, then for sure I'm going to advocate and say, hey, this guy has hyperfibrinolysis. Let's give this antifibrinolytic agent and give this patient the best shot that we can.
Well, I mean, viscoelastic testing is amazing, right? But unfortunately, it's called LY30 for a reason, right? It's the last result you get. It does not happen quick. So of course, exactly. We want to know their R time if we need to give PCC or, what's their AA or ADP inhibition and those kinds of things. But the problem is, right, when they're like massively exsanguinating in front of you and you're like, well, we got 22 more minutes till we get through.
Yeah, exactly.
It's hard to argue to not give the loading dose and then kind of cease, but it just makes it a little challenging. But that was when you first get used to it and you're like, oh, that's why it's called LY30. It's kind of like
exactly.
Okay, yeah. Well, Ruben, what an awesome discussion going into some of the nuances with. Wait. Well, I guess we need to ask, does tranexamic acid make your emergency medicine Mount Rushmore of drugs?
I think it does, but only because we get to use it in so many different ways. Not only for like trauma patients, but postpartum hemorrhage patients. Quick plug, Dr. Kelly Wang and I wrote an article on the uses of TXA and how they apply kind of to us in emergency medicine, emerging evidence for ACE inhibitor-induced angioedema.
Yep.
Like I said before in a different presentation, like TXA is like the Frank's Hot of bleeding. You'll put that stuff on everything. So, I still love it. I still think it's absolutely viable. Keep it stocked in your ER. Know how to give it, know how to prepare it, and know how to use it for the different indications.
So normally I would say we need to change that with sriracha. I'm a sriracha man, but we're on a pretty big shortage. So we'll allow the Frank's Hot substitution until we can get that beautiful red bottle back. Well, you likely know Ruben from his Instagram account. Follow him if not at the ED Traumacist. And then of course he is also on Twitter as well at the People's Ruben. 2023 co-social media star of the year. Ruben, appreciate you coming on. Thanks for highlighting the CRASH-3.
Thank you so much for having me, man. I appreciate it.
Yeah.
Thank you so much, man. I appreciate it, Nick.
Huge thanks again to Ruben for joining the pod, sharing his insights. Reach out to him, let him know what you think, as well as I always value your feedback. Please reach out to me at PharmacyToDose or PharmacyToDose at gmail.com. The reference list with some of the articles and guidelines that we covered today, that article on the TXA review that Ruben talked about that he helped write, that is in that podcast episode description, as well as the updated PharmacyToDose.com website. Hope you enjoy that. Still putting a little bit of work into it, but hopefully that is much more user and enjoyable friendly. And until next time, I'm Nick Peters, and this is Pharmacy to Dose, the critical care podcast.
The Critical Care PRN optimizes drug therapy outcomes by promoting excellence and innovation in clinical pharmacy practice, research, and education. For more information, go to critprn.accp.com. Again, that is critprn.accp.com. The podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. Use of the contents and materials on the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users and patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guests and should not be interpreted to reflect the official position or policy of ACCP or the Critical Care PRN. ACCP and the Critical Care PRN disclaim any and all liability or responsibility for any direct, indirect, incidental, special, consequential, or any other damages, including without limitation, loss of profits arising out of any use of, reference to, reliance on, or inability to use the podcast, its contents, and materials.